All right, bioheads of 211, this is Dr. Kaz, and I am back with this supplemental video due to the unfortunate event of the internet giving us some issues in class the other night. I am making this video here to cover the material that I thought I was recording but didn't get recorded. So that being said, I'm going to pick up where we left off on the nervous control system or nervous system control of breathing. Okay, I'm just going to backtrack a little bit and review the chemoreceptors here. When we're dealing with our nervous system, keep in mind that the chemoreceptors are going to be monitoring chemical levels, okay, in fluids. And the fluids of our system mainly are the lymphatic system, the blood circulation, and we're actually going to include the CSF, the cerebral spinal fluid here. And we're going to discuss that the chemicals that it's going to be monitoring are going to be the hydrogen ion concentration that basically determines how acidic or how basic your blood or CSF is going to be, the cerebral spinal fluid. And then also how much carbon dioxide and oxygen is dissolved in those fluids, how they will interact and cause chemoreceptors to send sensory information to the central nervous system and to determine what's the appropriate outcome for elevated or decreased levels of both carbon dioxide and oxygen. So there's two types of chemoreceptors. We have central and peripheral, and those represent the central nervous system, the peripheral nervous system. So when we're dealing with the central chemoreceptors, all right, these chemoreceptors are going to monitor the pH, all right, of the cerebral spinal fluid. And basically, it is going to monitor any changes in the cerebral spinal fluid's level of acidity or how basic it is in regards to, all right, the amount of carbon dioxide that is going to be present there. Okay. Now we'll go into a little bit more detail about this, how this happens later on. All right. But the carbon dioxide is going to move from the blood into the CSF. And this is where we have carbonic anhydrase. And that's going to be an important component for our buffering system. All right. And what we'll see is that this carbonic anhydrase is going to create or help to form the carbonic acid, all right, from carbon dioxide and water. Okay. So carbonic acid comes from both carbon dioxide that is dissolved in the blood and combines with the water to form carbonic acid. And so that is going to be an important component when we're regarding the pH level, all right, of our CSF. All right, now the peripheral chemoreceptors, which are located in the aorta, the arch of the aorta, and the carotid bodies, which is going to be located in the common carotid region there. Okay, this right here is going to have two possible chemicals that it monitors. Again, changes in levels of the hydrogen ion concentration and changes in levels with the carbon dioxide and our oxygen, or the respiratory gases that are present in our blood. Okay. So again, when we're dealing with with the hydrogen ions, all right, we want to consider ketoacidosis. And I know we haven't really talked about this too much, and we'll get more into it when we get into the metabolism. All right, but ketoacidosis, all right, is going to be a process that occurs, all right, when we're breaking down our fatty acids, all right, and we'll see this more so in folks that have insulin issues, okay, primarily diabetics, and we'll see as this hydrogen ion concentration increases, all right, it can actually impact the pH, decreasing the pH, making it more acidic in our blood, okay, and this does work independently, or this occurs independently of our carbon dioxide levels here. All right. Keep in mind that the carotid chemoreceptors operate by cranial nerve number 9, the glossopharyngeal nerve, and the aortic chemoreceptors are going to operate via the vagus or cranial nerve 10 nerve. Okay. Okay. So a couple other types of receptors. We have the irritant receptors, the baroreceptors, proprioceptors. All right, irritant receptors, again, when you're breathing things in, you're bound to breathe in particulates depending on where you live. If you're outside in an urban area, or you could be in an area that's heavily populated with pollen. All right. Point of the matter here is that these irritants, when they're inhaled, right, these receptors will pick up on them. We talked about them briefly when we were discussing the carina, which is located at the bifurcation of the trachea into the left and right primary bronchi, okay? And these irritant receptors will be stimulated if you get like a dust particle or pollen particles in there. And it'll help to invoke, we'll talk about the effects of this in a little bit. It'll help to invoke the sneeze or the cough reflex to try to clear your airway passage. Baroreceptors, we saw those before when we were talking about circulation, right, are pressure related due to the amount of stretch on the vessel walls. Well, in this case, our baroreceptors are going to be located in our bronchioles, the tubing there of our respiratory system, and the pleura, okay, the layers there of our serous membranes. All right, and finally the proprioceptors, and this one here has always been an interesting one to me because proprioceptors, I never really gave it much mind or thought in regards to how it impacts breathing and whatnot. But as we remember from the previous class in Bio 210, we talked about proprioceptors, or these receptors that are located in muscles near the tendinous insertions and the joints themselves, all right, and they monitor the movement of those muscles and joints, and they send that information back to the central nervous system, all right? But these proprioceptors will also play a role, all right, when we are having increased activity or certain amounts of activity on your respiration rate, which makes sense because when you're exercising, most likely you're going to be increasing the proprioceptive activity there, and so you'll be sending more information to your central nervous system, and so you'll want to increase your respiration rate to meet the energy demands of a lot of those tissues there. This picture here is just basically just kind of showing us all the different structures that are going to provide input into the central nervous system or the respiratory centers there. Okay, so you can see here, all right, we do have, all right, our baroreceptors, the proprioceptors, all right, and they're going to be sending sensory input here into the respiratory center in the medulla oblongata, along with our chemoreceptors in both the peripheral and the central nervous systems, all right, and so they'll also be inputting information into the respiratory center of the medulla oblongata, okay? And so then, as a result of whatever that input is, then the effector output is going to move out here, mainly to skeletal muscles, all right, that are going to change, all right, the respiration rates, the force of respiration. If there are irritant receptors, we need to clear that airway or that area there that we notice that there's particulate matter in, and so we'll respond with the appropriate reflex to help to benefit us from that. Okay, so let's talk about, all right, how the nervous system is operating as you're sitting here watching this video, listening to every word that I say, hanging on it, all right, and basically what is going on, okay? So we're going to start off, all right, remember that breathing has two phases, the inspiratory phase, right, taking a breath in, and then the exhalation phase or the expiration phase, taking a breath out, okay? When we start off with inspiration, all right, we are going to stimulate the neurons here in the ventral respiratory group, okay, in the medulla oblongata. And so they're going to send their sensory input down to the effector organ, which is going to be the skeletal muscles, all right, about every 2 seconds. This is just for the first part, the inhalation, taking a breath in, okay? So those skeletal muscles primarily during quiet breathing are going to be the diaphragm and the external intercostals, okay? So those are going to do their thing, increase the thoracic volume, decrease the pressure, and it will all allow air to flow in, okay? So that takes about 2 seconds. So then, at the end of inspiration, we will follow it with expiration, exhaling, okay? And so now in this situation, we are going to inhibit, all right, the ventral respiratory group, okay? And in doing so, all right, we are going to stop stimulating the diaphragm and the external intercostals, and therefore they will relax, okay? And so according to that, as we cause them to relax, then our muscles then will return everything back to their original position. This takes about 3 seconds, all right? And this will then, of course, decrease the thoracic volume, thereby increasing the pressure inside and causing air to flow out. Okay? All right. The second part, the expiration, is based on the negative feedback system. So I'm sure you're familiar with that. We learned that in Chapter 1 in Bio 210. Okay, so keep that in mind that we're dealing with that negative feedback system in regards to the expiration there. Okay, so basically that takes about 5 seconds for that whole process. Breath in, breath out. All right, well, all right, multiply that or divide 60 by 5 seconds, that's roughly going to be about 12 seconds on average. Okay, 12 seconds, or excuse me, 12 breaths per minute. Okay, so the average rate of breathing, okay, is going to be 12 to 15. Again, like I've said before, I've seen in some literature that it's 12 to 16, 12 to 18. Regardless, we're going to stick with this number here, or this range here. It's 12 to 15 breaths per minute. Okay. Now, while this is going on in the medulla oblongata, okay, the pons, all right, is also going to be playing a role, because the pontine respiratory center, all right, its job is to maintain that smooth transition between taking a breath in and the breath out. All right, and so what it'll do is it'll send information to the medullary respiratory center. All right, and it helps with that smooth transition, so it prevents erratic breathing. Okay, as you transition from inspiration to expiration, because without it, okay, without the pontine respiratory center, these people will just have, it'll sound very odd. It's hard to do it on the video here, but it will sound like this, kind of. It's hard for me to talk and do it at the same time, kind of like that. And now they're not going to be really short of breath. But what will happen is that they just lack that smooth transitioning between a breath in and a breath out. Okay, so that's with normal, quiet breathing as we're all sitting here relaxing. So now we're going to talk about a couple of things that are going to change, all right, the rate at which you breathe and the depth, how deep a breath that you take in or how deep a breath you have to force out. Okay? So in this situation, we're going to again be dealing with certain receptors. Okay, and of course our chemoreceptors, all right, are going to be monitoring the chemical components of wherever they're located. If it's in the cerebral spinal fluid, or if it's in our regular blood circulation there. Okay, so when we're dealing here, first the messages are going to be sent initially to the dorsal respiratory group. And then those input signals will then be transmitted to the ventral respiratory group. And it's the ventral respiratory group that is going to, again, all right, alter the rhythm or the rate of breathing and how forceful our breathing is going to occur. Okay? So basically, it's going to help to stimulate those accessory muscles, those muscles that we need, all right, to help take a deep breath in if need be, or to have a forceful exhalation if need be. Okay? So in certain situations, if we see, okay, an increase in the amount of hydrogen ion concentration in our cerebral spinal fluid, okay, thereby meaning our cerebral spinal fluid is becoming more acidic, the pH levels are dropping down, we are going to see an increase rate in ventilation. Okay. If our peripheral chemoreceptors note an increase in the amount of hydrogen ion concentration in the blood or the amount of carbon dioxide in the blood, same thing. We'll get an increase in the ventilation rate. Okay. So as this occurs, and I've seen this asked on tests before, okay, as this occurs, we see an increased ventilation, okay, force of breathing, rate of breathing, all right. As this occurs, we're going to see, all right, the lungs get rid of more carbon dioxide. Well, that's great, okay, as we breathe off the carbon dioxide, because remember, carbon dioxide and water, all right, are going to help to make carbonic acid. All right, we'll get into that when we talk about the buffering portion here, okay? but that plays a role in the pH value of our blood or the cerebral spinal fluid. Okay, so if we increase, all right, our breathing, all right, then we can get rid of more carbon dioxide, and therefore we can decrease, all right, the amount of hydrogen ions that are present, basically increasing the pH value, getting us more towards neutral, 7.4. That's our goal, 7.4. Okay. So if we see conversely, if we see decreased levels of hydrogen ion or, all right, carbon dioxide, then our ventilation will decrease. Okay. All right, now when we're dealing with our concentration levels of carbon dioxide in the blood, okay, and I do believe I mentioned this before, or at least I think I mentioned it in the video that got erased, okay, but in our blood, all right, the amount of carbon dioxide plays a much larger role than the oxygen levels. And you would think it'd be the other way around, okay? But the blood carbon dioxide levels is going to be the most important factor or stimulus affecting our breathing, okay? So if it changes by a value of 5 millimeters of mercury, we can double the breathing rate, okay? That's how sensitive, all right, the chemoreceptors are to carbon dioxide levels, okay? Because the more carbon dioxide we have, all right, the more it'll interact with water and the more it'll form carbonic acid. We increase the carbonic acid, we're increasing the acidity, okay, and we're causing pH levels to drop. And if we cause the pH, if we cause a significant decrease in pH, make something more acidic, right, then we are going to see, all right, several different changes occurring, all right, but one of which is called denaturation of proteins, and that's bad. Remember what all the functions of proteins? So if we start to basically unravel and destroy these proteins, they are going to cease functioning appropriately, all right? And as you know, proteins play a large role in pretty much every aspect of homeostasis, every aspect of our functionality in life, okay? So that's a problem, okay? Issue is, with the cerebral spinal fluid, it lacks these protein buffers, okay? So that just makes it that much more sensitive, all right, to the changes in the levels of the carbon dioxide levels in the in the CSF. And so any little bit of pH change is going to immediately trigger these reflexes that we talked about, okay? Increased ventilation, force of the respiration, the breaths that we take, and the rates. Okay. All right. So we're going to see that oxygen is not as sensitive. Okay. And you'll have to see a really large change. It has to go pretty much, all right, 35 millimeters of mercury, a difference of 35 millimeters of mercury compared to just 5 millimeters of mercury with a differential with carbon dioxide, okay? But oxygen will have to have about 35 to have any type of major effect, all right, on your rate of breathing, okay? All right, one more fact. If we see a decrease in oxygen levels, all right, in the peripheral chemoreceptors, not in the central, but in the peripheral, this is an interesting kind of functionality, all right, of this system, is that it makes, all right, the peripheral chemoreceptors even more sensitive to the levels of carbon dioxide in the blood. Okay, so again, so we can initiate these reflexes and kind of kick things into gear. Breathe off that carbon dioxide, okay? Breathe in more oxygen, okay? All right, so we talked about proprioceptors. Okay, and we're going to see now pretty much what effect they have, all right? So again, we know that proprioceptors have to do with body movement. So when you start to increase body movement, like exercising, for example, all right, that is going to send signals to the respiratory center to increase, all right, the rate, it's not the rate, but the depth, all right, because you're going to be then stimulating the involvement of the accessory muscles. Okay. Stretch receptors, the baroreceptors, all right, we said that those are both in the pleura and the bronchiole, okay. All right. So these guys will be stimulated, especially if more air is being forced into the respiratory pathway there, all right. These baroreceptors prevent those structures from being overstretched. Really cool reflex is called the Hearing-Brewer reflex, okay? And basically, similar like a balloon, if you blow into a balloon and you keep blowing and keep blowing and keep blowing, the balloon will pop, okay? Well, that could potentially happen to the alveoli, okay? So as you're, inhaling or inspiring, all right, the alveoli keep increasing in volume, okay? And they could potentially become damaged. Well, this reflex pretty much shuts off, all right, your inspiration at a certain point. And then everything returns back to its normal configuration or size. All right, then our irritant receptors, sneeze reflex and cough reflex. All right, again, we will see in this situation an irritant has managed to make its way into our respiratory system. It can be anywhere, nasal pharynx, the nasal cavity, nasal pharynx, oral cavity, oral pharynx, larynx, any of those areas, trachea, all these have these irritant receptors. All right. What we'll see is once that's triggered, we'll see a closure of the larynx, of your voice box, shut that off. All right. And then the abdominal muscles, and we've all done this before with a sneeze or a cough, the abdominal muscles contract. All right. And that builds up a forceful blast of air to help clear out the area, right? Make sure that we've expelled, right, any of the irritants or particulate matter there that initiated the reflex to begin with. Okay. A couple other areas that we don't really focus on too much, but are worth mentioning. The hypothalamus. All right. The hypothalamus is going to help play a role here. All right, in which we'll see a temperature increase in our body. All right, so if you start to warm up or heat up, okay, most of the time, all right, that will be with athletic activity or an increased activity. I shouldn't say athletic activity, but increased activity. All right, and of course, if there's increased activity, doing some chores in the yard or maybe going for a run, then your body's going to respond to that because the cells, the tissues, therefore have increased their metabolism. Right, and most likely probably need more oxygen to those tissues for ATP production. All right, we will see the hypothalamus then trigger an increase of ventilation in the respiratory center. We'll see it with fevers also. All right, limbic system. All right, we'll see that. Remember, limbic system, think emotions. Always emotions when we're dealing with the limbic system. Okay, same type of situation. I love my daughter very much, but sometimes she's a very sensitive child, and sometimes when she gets a little bit of emotional, it'll affect her breathing rate, almost to the point where I'm not saying that she's hyperventilating, but it will increase her ventilation rate. And so I always have to kind of remind her, okay, a couple deep breaths, just calm down a little bit, let the emotions work themselves out. But this is just showing you, how the limbic system can also, all right, make a change in the breathing rate, the ventilation rate there. And then we got our frontal lobe. Well, as we know, our frontal lobe is going to be where all conscious thought occurs, and personality, a lot of our higher orders of thinking, okay? And it's the frontal lobe that can actually invoke, all right, voluntary changes in breathing patterns. For example, I want to take a deep breath. I'm swimming. I want to swim from one end of the pool to the other, underwater. I'm going to hold my breath. And that's what happens with the frontal lobe, okay? The frontal lobe can bypass the respiratory center, go directly to the lower motor neurons. Example, all right, the phrenic nerves and the intercostal nerves. Okay, and some of our other sympathetic neurons too that will, well, not the sympathetic, but some of the other neurons, lower motor neurons that will help affect some of the accessory muscles to take a deep breath in. Okay? All right, and finally, all right, when we're discussing some of the other parts to our respiratory system, all right, that are still included, we cannot forget about smooth muscles and the glands. All right, the glands are present, mainly in the mucous membranes there. Right? We've seen, for example, the goblet cell and whatnot. Okay. So these tissues here, smooth muscles and glands, fall under effector organs. All right, and those are operated by the autonomic nervous system. Okay, specifically the lower motor neuron portion of that. All right, but of the autonomic nervous system. So we don't have voluntary control over that. Okay, this will be located in the autonomic brainstem nuclei there. Okay, and then when we're dealing with our skeletal muscles, yes, skeletal muscles are under voluntary control. Thereby, they are controlled by the somatic nervous system. All right, specifically the lower motor neurons. Okay. And so, in addition to the cerebral cortex, all right, in the frontal lobe there, right, we also have the somatic nervous system, which we know, right, but we still have the brainstem autonomic nuclei because they will take over. Okay, if you pass out for whatever reason, the brainstem autonomic nuclei will take over with the breathing. Because if it didn't happen, you'd be dead if you passed out. Okay, depending on how long you passed out for. Okay, so keep that in mind. So yes, we do see that there's both reflexive and conscious controls of breathing. All right, but we have backup mechanisms that if the conscious controls of breathing, all right, fail, all right, we can count on our reflexive controls for our breathing rate. Okay, let's jump into airflow. All right, we saw flow before when we were talking about, I'm not talking about flow from the Progressive commercials. All right, I'm talking about flow when we see blood, all right, moving through the circulatory system. Okay, similar equation. Okay, so when we're dealing with flow, we're going to be dealing with a pressure gradient, right? And if we're dealing with a pressure gradient, that means we have to be dealing with at least two areas. Okay, and in one area, the pressure is going to be higher than the other area. Okay, we saw it in our circulatory system. All right, the pressure gradient coming right out of the heart in the aorta, all right, was very high compared to the pressure in the vena cava, all right, which was very low, virtually zero. Okay, so we're going to be dealing with the pressure gradient here, all right. So our 2 points that we're going to deal with are the first is going to be the atmospheric pressure outside of our body, and then the pressure inside of our body, the intrapulmonary pressure. So those are going to be our 2 places. Okay, and then we're also going to have to deal with, when we're talking about flow, is resistance. Okay, and so this is going to include, all right, the airways. All right, so everything, including your nasal cavity, nasal pharynx, oral cavity, the oral pharynx, all the way down through the trachea, all right, through the bronchioles, all right, the lungs themselves, those tissues, the alveoli, all right, and the chest wall. Okay, because remember, all right, that Boyle's law, we are going to be manipulating the chest wall, all right, and therefore, if we manipulate the chest wall, we're going to manipulate the inside thoracic cavity, making it bigger, all right, and then returning it back to its original size. Okay, so that's all that has to play a role in resistance. Okay, so airflow, here's a nice equation for you. Remember this one. Airflow, okay, is delta P over R. Okay, so F is flow, right? Delta P, the delta sign means a change. Okay, so there's going to be a difference. We're going to take that pressure gradient, all right, and we're going to start off. Remember, our our atmospheric, all right, pressure is going to be constant, 760 millimeters of mercury. Okay, it's not always going to be constant, but for our purposes, for this class, we're going to keep it constant unless otherwise notified. Okay, and then we're going to subtract the intrapulmonary pressure, which is annotated by alveoli. Okay, so we're going to take the difference of that, and then we're going to divide that value by the resistance. Okay, so keep in mind that flow is directly related to pressure. What does that mean? Okay? If I increase the pressure, I will increase the flow. All right, that's what it means. Directly related. If you increase one, you'll increase the other. But, okay, flow is inversely related to resistance. If I increase the resistance, I decrease the flow. So inversely related means if I increase one, I decrease the other. Okay? So just like it says down here, if the pressure gradient increases, air flow to the lungs increases. Simple. Okay? If the resistance increases, airflow lessens or decreases. All right, it's crucial that you know that. Okay, it's a good concept to know. Very, very important. Okay. So let's talk about pressure gradients. All right, and pretty much we know when we're dealing with pressure, all right, especially if we're going to be dealing with the pressure inside of the lungs, then volume is going to play a role in that. Okay, so just to review, pressure gradient is the difference. That means we're going to subtract one value from another, right? And those values are going to be the pressure in the atmosphere outside of our body, in the room, in your car, outside, in your front yard, all right? And then the pressure inside your body, right? Inside the lungs, the intrapulmonary pressure, all right? And we can change the intrapulmonary pressure by messing around with the volume of the thoracic cavity. Okay? Boyle's law. Increase the volume of the thoracic cavity, decrease the pressure inside the lungs. The intrapulmonary pressure will decrease. And vice versa. Okay? So as I'm sitting here, okay, and as you're sitting here, all right, watching this video and listening, all right, your normal breaths in and out, you're going to move about 500 milliliters or half of a liter of air, all right, into your lungs. Okay? As you blow it out, okay, you remove 500 milliliters of air from your lungs. Okay? So that's just quiet, normal respiration. Now, if you want to take a deep breath in, or if something else is going on, if you're exercising, okay, now you're going to be recruiting the accessory muscles. All those muscles that we talked about at the beginning of this chapter that help you to take a forced breath in and a forced breath out. Okay? So in this case, the accessory muscles of inspiration, all right, are going to increase the thoracic volume or the thoracic cavity volume. So that means, all right, we are going to make a greater difference in our pressure gradient, which means the airflow is going to increase due to that greater pressure gradient difference. Okay, so 760 millimeters of mercury in the atmosphere. Okay, I want to take a big breath in. Take a deep breath in. Okay, now the pressure inside my lungs has dropped down to 757. Okay, it means it's a difference of 3 millimeters of mercury compared to a difference of 1 millimeter of mercury during quiet breathing. Okay, so we're going to see an increase, all right, in the pressure gradient. Therefore, we're going to see an increase in airflow. Okay, so we might go from 500 milliliters of air to 700 milliliters of air. Okay. All right, so let's address the other factor in our airflow equation, and that's going to be resistance. Okay, so resistance is on the bottom part of that fraction there, and we said that it is inversely related to airflow. So if we increase resistance, we're going to decrease airflow. Okay, so some of the factors that are going to make resistance increase, all right, we are going to be a decrease in the elasticity of the chest wall or the lungs. Okay, if we change the diameter of the bronchioles, well, we saw that before in the circulatory system when we caused vasoconstriction. All right, we made the diameter smaller, we increased the resistance there. And then also if we see the collapse of the alveoli. Okay, so we're going to go through these and talk about these individually here. Okay, So resistance is going to be any of these factors that are going to make it more difficult to move air into and out of the lungs. Okay? Again, that could be a change in the elasticity of the chest wall and lungs. All right? We can alter the bronchial diameter, make it bigger or smaller, or collapse of the alveoli. Okay? Normally, if we're going to increase resistance, we'll make the bronchial diameter smaller. Okay, so let's go through. Okay, so the first component is going to be elasticity. Okay, so we're going to decrease the elasticity of the chest wall. All right, this is a normal aging process. All right, but also, all right, we'll see it in certain disease states. All right, a very common one is pulmonary fibrosis, scar tissue. Okay, we saw that chapter 6. We learned the difference about what fibrosis was versus regeneration. All right, and essentially fibrosis is scar tissue. Okay, as we age, our overall ability to make those protein fibers, the elastic protein fibers, decreases. So therefore, our chest wall, all right, will become less elastic. In certain conditions, if you have scoliosis due to the vertebral column, all right, imposing in onto the pleural cavity, we can see that occur, all right, and in some cases it's really bad, and there's a condition called Pott's disease in which scoliosis and the thoracic vertebral spine gets so completely messed up, curved, twisted, turned. All right, it's a hot mess in there, and that will significantly decrease the elasticity, all right, of the chest wall. Okay, arthritis. Okay, if we start to see, you know what arthritis is? It's degeneration of joints. All right, and there's joints involved. All right, throughout the thoracic cavity. Okay, you've got the joints of the sternum on the clavicle, sternum on the ribs. Okay, the ribs on the vertebra. Okay, so if you start to get arthritis in any of those joints, arthritis usually is followed or accompanied with a decrease in movement. All right, that decrease in movement, all right, will decrease the elasticity of the chest wall. All right, then you already heard me talk about pulmonary fibrosis. All right, again, the elastic tissue that we'll see in those alveoli that we saw in lab, all right, it gets replaced with scar tissue, and it just does not allow the alveoli to rebound, all right, after they've been expanded with inhalation. Okay, they have a much more difficult time moving back to their original configuration and size. All right, so that's the first component of resistance. The next one is the bronchial diameter. We're very familiar with this already. Okay, so we have bronchoconstriction and bronchodilation. Okay, bronchoconstriction similar to vasoconstriction. All right, we're going to decrease the lumen. Okay, and so as we decrease the lumen, all right, or the diameter of the bronchioles, all right, we will increase the resistance. Okay, so this is seen in a couple different situations: parasympathetic activity, histamine release, believe it or not. Okay, and we see histamine release triggered through allergic reactions or just the cold. Now we're blessed down here in South Carolina that we don't have to really experience too much with the cold here. It's not so bad, but for those of you that have lived or been up in the Northeast or even anywhere up north, all right, in the dead of winter, it gets very cold there, and that cold atmosphere, all right, will cause a reflex or a reflexive constriction of the bronchioles there. Okay. We'll also see items, for example, okay, folks that have allergies or asthma will have excess mucus production. All right, and that excess mucus production will help to occlude the lumen, all right, and make it much more difficult for air to move through the passageway there. Inflammation too, okay? Again, we'll see that with a plethora of different types of conditions, but if you have any type of inflammatory condition that affects, for example, COVID, there's a perfect example, okay? COVID has been shown to cause inflammation of the bronchioles, makes it much more difficult for people to breathe. And then the opposite of the bronchoconstriction is bronchodilation. Obviously, when we have bronchodilation, that is going to increase the lumen, right? So therefore, it'll decrease the resistance. We'll see that through sympathetic stimulation, okay, through exercise, fight or flight, and then epinephrine, okay, adrenaline, okay, helps to cause bronchodilation. So the last component here when we're talking about things to affect the resistance is going to be the alveoli. If an alveoli becomes collapsed, okay, we'll see an increase in resistance here, okay? And this is common for premature infants, and that's why it's really important for premature infants to stay inside mommy for as long as possible if they have to come before their due date, because for this reason, specifically for alveolar type 2 cells. These are the cells that produce surfactant. And it's the surfactant that allow the alveoli to stay open, okay? They help because remember, there's a force, the elastic tissue is trying to pull them closed, all right, but not collapse them so much, but it pulls them inwards, and the surfactant helps to keep them patent and open, okay? Well, unfortunately, premature infants will not produce surfactant until after week, it's either 23 or 26. Off the top of my head, I can't remember, okay? So if they're born before that point, they're not able to produce the surfactant, okay? And so that will cause collapse of the alveoli. All right. So when we see that, because they don't have that surfactant, all right, and we have that increased resistance occurring, we give it a name. And we call that respiratory distress syndrome, or RDS. Okay. So that's why it's really important to help to get these cells to produce that surfactant. One way to do it is to give them steroids. Okay, that is one treatment. Doesn't mean it's going to necessarily work. Depends on how close they are to that week mark there in their development. All right, between 23 to 26 weeks. Okay. All right. So that leads me to talk about compliance, and this is a term that you want to be pretty familiar with here when we're talking about how easy it is for the lungs. And not only the lungs, but the chest wall to expand as you're taking a breath in, okay, during inspiration. Okay, so what helps to determine compliance is going to be that surface tension from surfactant and the elasticity that we just talked about just a little bit earlier, the elasticity of the chest wall and the lungs. Okay. So basically what compliance is the ease to which the lungs are able to expand through inhalation, all right, and how well, if they can go with no problems, the greater the compliance. Okay, so if you have pulmonary fibrosis, okay, you're going to have all that scar tissue, you're not going to be able to expand the chest wall as easy as you once were, so therefore you're going to experience a decrease in compliance. All right, and finally, a couple things that will increase resistance to the airflow. All right, decrease the size of the lumen, see it with asthma. Decrease in compliance, what I just talked about, pulmonary fibrosis. All right, these things, all right, will increase or will decrease that airflow due to that increase in resistance. So in order to make up for that, we are going to then have to take in a deeper breath, which means we are going to have forced inspiration, and in some situations we'll have to have forced expiration. Okay, so normally when you see an increase in resistance, we are now going to have to transition from eupnea, all right, to forced inspiration, and in some situations, forced expirations. And because we're having these forced inspirations, that means we need more energy. okay? Roughly about 4 to 6 times the amount, because we're recruiting more muscles, all right, and we have to work a little bit harder. So that's why you'll see folks, and if you ever, and I can attest to this, having asthma, all right, if you see people with emphysema, I'm trying to think, anybody that has a type of pneumonia, they will be exhausted, because in order to what we take for granted, you and I, me, when I'm not having an asthma attack, what we take for granted for that normal breathing becomes compromised, and now in order to get the same amount of air in and out, all right, we actually have to utilize more energy to do it, because we're recruiting more muscles, and we have to overcome more forces, all right. We're going to be utilizing more ATP. And that's why a lot of these people will look tired all the time or exhausted. Okay, I'm going to stop here. This is a good breaking. This is actually what I wanted to get to in the other class, because we're going to start talking about pulmonary and alveoli ventilation. We're going to start talking about a really important equation here. I'll just kind of give you a preview. Tidal volume times respiration rate is equal to pulmonary ventilation. We're going to learn how to calculate, all right, pulmonary ventilation, all right, how much air that you're going to move, all right, in and out of your lungs in a minute. Exciting, I know. But you'll have to wait until Wednesday, okay, or to our next class, I should say, depending on when you're viewing this. All right, folks, it's been a pleasure. I hope I didn't bore you too much. I know I didn't. I hope I didn't move at a pace that was hard to follow. Have a great day or evening or morning whenever you're watching this. I look forward to seeing you all in class. All right, have a good one.